Welcome, everyone. I'm Doreen Zetterlund, CLL patient, patient advocate, and a member of CLL Society's Patient Advisory Board. We're here today with CLL Society's Facebook Live event, Ask Me Anything, where we spend the next 60 minutes answering your questions with a CLL healthcare expert. And we're so lucky today to have Dr. Jackie Broadway-Duren joining us. There are no presentations, and we encourage you to ask questions on the Facebook page if that's how you're joining us, or through the Zoom platform. This event is dedicated to your questions, so make sure you ask them early, and we'll try to get to as many of them as we can. Before we begin, I have a few important disclaimers to share. Nothing said today should be taken as medical advice. Any questions about your health and treatment should be discussed with your healthcare provider. The information you post on Facebook will be shared in a public forum, so please don't post anything that's no confidential information. And without further ado, Jackie, would you please introduce yourself to our audience?
Good afternoon. I'm so excited to chat with you guys this afternoon. Some of you I may know and some may not, but maybe by the end of this event, I will get to know you at least verbally and on video. My name is Jackie Broadway-Duren. I am a family nurse practitioner. However, I'm also an oncology nurse practitioner. I have a PhD and doctor of nursing practice as well. And no, I don't just enjoy going to school, but I've been working at MD Anderson for 24 years now in the Department of Leukemia. And so my specialty area is CLL. And I'm just elated to be here with you today, and hopefully I can answer your questions satisfactorily and give you some good information. Thank you.
Great, thanks, Dr. Jackie. We'll go to our first questions, but it's okay if I call you Dr. Jackie?
Yes, fine. That's absolutely fine. Thank you.
Okay, great. How long after completing treatment will my immunity be restored, and to what degree as compared to a non-CLL person?
Oh, so it really will depend on age. That's a factor, and it depends on what treatment regimen that you were treated with. But in general, it takes several months and maybe sometime up to a year before your immune health recovers. Blood counts should start to improve, meaning that if your hemoglobin has been low because of treatment or the platelets have been low, once you have completed treatment, in about 6 months, you should those numbers and values should start to return as close to normal. Now, I have to tell you, in some cases where persons have been treated with actually chemotherapy, it may take longer, and sometimes you may not get 100% recovery back on those counts for a couple of years.
Okay. Next question. How long does an IVIG infusion remain in peak force? And is there a benefit in receiving these infusions at less than 4-week intervals?
Yeah, so IVIG usually has a half-life of about 3 to 4 weeks and lasts in your system for up to 3 to 5 months in most cases. So the it provides areas of making enough of, so therefore that's the benefit of it. However, no, it doesn't really benefit you to just take it more frequently than a 4-week interval.
Okay. All right. As a CLL patient in watch and wait with a pressing concern with an enlarged spleen, would it be beneficial to undergo a splenectomy, or instead to begin treatment to avoid that occurrence? There are no other B symptoms or indications for treatment.
Okay, well, let me start out by saying we almost never recommend a splenectomy unless there is some severe problems going on with the spleen and you have severe hemolysis, meaning that the spleen itself may be producing antibodies that are attacking the red blood cells and platelets and causing destruction. Outside of that, we do not recommend splenectomies. And if So while you're on watch and wait, I know this is a difficult time. I hear it all the time. I've heard it for years. I probably would be a little bonkers myself if I had to just watch and wait. However, we do not recommend splenectomies just routinely because we know that the spleen is enlarged. It is of no benefit. You need your spleen. It houses extra blood supply.
Okay, great. Um, is it common for CLL to affect the lungs and cause shortness of breath and wheezing?
No, that is not common. Um, Now, in cases where patients have, which is rare again, there have been some cases where patients have had some CLL infiltrate into the lungs tissue, but that's uncommon. So no, that is not common for CLL to affect the lungs and cause shortness of breath and wheezing. So I would suggest in that case that perhaps you should see a pulmonologist and get a full workup done and see if there may be some underlying autoimmune disease or some other type problems that may be affecting the lungs. But that's not common for CLL. Now, there are certain treatments that may predispose you to lung problems, but routinely outside of that, no.
Okay, this question seems to be maybe related. How common is pleural effusion in CLL patients? And if you could explain what that is, and does CLL cause this?
Again, generally, CLL does not cause pleural effusions. Now, if you have many of our patients are CLL is known to be an older patient population, so many of them have other comorbidities that may be contributing to this. But generally, no, we don't just see pleural effusions in CLL. Now, so let me explain what pleural effusions are. So you have two lungs. I'm sure everybody's aware of that. There's a lining around the lung that is called the pleura, a sac that holds that conceals the lung tissue. And so what pleural effusion is, there's a buildup of fluid in that space inside that pleural sac. Sometimes pleural effusions can come from infections. So if you, for instance, have been treated with something with the chemotherapeutic or chemoimmunotherapy for CLL, you may develop pleural effusions because of the treatment itself, but not just the disease.
Okay. Uh, Next question here. How can I determine if my fatigue is CLL-induced fatigue or potentially caused by menopause-related sleep deprivation or other events causing lack of sleep?
That is a very good question. I ask myself that daily, how can I determine what is the cause of my fatigue? uh, but all jokes aside, sometimes you can't differentiate whether the fatigue is CLL based or whether it's menopause. If you're menopausal, some of my patients have described this as a double whammy for them. We do know that with CLL, particularly in advanced disease stages, that the fatigue happens as a result of the autoimmune complications that's going on. But I'm sorry, I didn't mean to say autoimmune. The fatigue comes because of the increase in cytokine activity with CLL as the disease progresses. So sometimes it's hard to differentiate whether the fatigue is coming from CLL or menopause. The best thing I would recommend is for you to make sure you follow up with your gynecologist, and maybe they can test your hormone levels and so forth and see if there's any indication that that may be causing fatigue. Now, if you have CLL advanced disease and you have anemia where your hemoglobin is low, anytime you have a low hemoglobin, less than 9, I would say, or 10, if you normally have a robust hemoglobin of 14 grams as a female and all of a sudden now you're down to 10, you're going to feel more fatigue. Guess why? Because the hemoglobin carries that oxygen component throughout the lungs, throughout the body and to the lungs and all tissue. if your as the hemoglobin drops, you have less circulating oxygen. So yes, you're going to feel more tired and fatigued.
Okay. Um, is there anything specific that CLL patients can do to avoid getting chronic fatigue? And the questioner says, being told to just deal with it or get yourself moving is not always helpful.
No, it's very difficult for a patient to understand when you tell them you need to exercise when they're telling you I'm back on the sofa by 11 or 12 o'clock in the day. So there is some truth to that, however. Um, so the first thing you want to do is make sure that you well hydrated, that you're drinking lots of fluids, and try to stay active, even if that means walking to the mailbox and back to the house. If you can do that a couple of times a day, that will also help you. The other thing you want to do is make sure that your primary care or your oncologist or whomever you see frequently check your iron stores to make sure you don't have an iron deficiency anemia or B12 deficiency, and also check vitamin D levels and make sure you have adequate amounts of vitamin D in your body. So those are some things, but just stay well hydrated and try to modify your diet. Believe it or not, foods that are high in fat and a lot high cholesterol and those things, as they break down, they weigh the body down, and that will cause more fatigue. So those are some of the tips that I can recommend to you.
We've got a little section of fatigue here, questions, so we'll just keep going. Short of getting a boost in energy on 2 days, I inject testosterone. Fatigue plagues me constantly. Is there anything I or the oncologist can do to lessen this occurrence?
No, basically, I would recommend the things that I just talked about. The other thing that always has to be considered, so what I found out in my practice, I did my dissertation on autoimmune diseases. So I found out since that time that several patients in my practice actually had an underlying autoimmune disease. So I'm not saying everybody has autoimmune disease, but what I'm saying is that may be an avenue to explore if you have any kind of autoimmune disease, and there are many, but the ones I've seen commonly in my practice are rheumatoid arthritis, sarcoidosis, lupus, those type things. They can draw inflammatory markers and see if those are elevated, then maybe you need to be referred to a rheumatologist. But that's the other thing. Exercise as best you can. Yoga is a great exercise, and then just if you know some therapists or at gyms and so forth have relaxation classes where they teach you relaxation techniques. All of those things may help to improve fatigue.
That's you have to search for a number of issues. I know I went through really intense fatigue, and that was part of the start of my reason for my treatment. And we checked everything, we thyroid and
Yeah.
everything. So you kind of check them all off the list, and once everything is managed, then you still got fatigue, and then you just have to try to find a way. And I do find finding a sweet spot in exercise, not too much, not too little, just sort of a sweet spot is helpful.
You don't want to, one thing I want to point out is you don't want to overtax your body. Because I had a patient who told me they were trying to run 10 miles a day. And I said, that's just not reasonable. That's why you even more fatigued. But do a reasonable amount of exercise. And I think yoga and meditation exercises also may be helpful.
Yes. Is there a connection between having a lower than normal range LDH, which is lactate dehydrogenase, and my experiencing increased fatigue?
Well, actually, what the LDH is, it's an enzyme, and it elevates outside of cancer. It elevates with muscular insult, like if you have an injury to the muscles or things like that. So that can certainly increase your LDH level. So I guess, but as far as CLL, as the LDH increases, we use it more like a tumor marker. As it increases, that tells us that your disease is likely progressing. So yes, that's the correlation. Then it would indicate that if you have increased disease, you're going to have likely have the fatigue that accompanies it.
Okay. And does having CLL or SLL increase the occurrence of having cold sores? And if so, how and why?
Okay, so cold sores, basically, there are a few exceptions, but basically those are the herpes simplex virus, type 1. Oh, and so let me give you just a brief uh, lesson on the physiology of why your immune globulins are low and why these opportunistic viruses just kind of get in there. Because as CLL cells, when they are produced in the bone marrow, as they go through that maturation phase and they reach maturity, at that point, some of those good lymphocytes, B lymphocytes, should go out into the plasma and become immune globulins or memory B cells to remember if, oh, she's had that before, so let me start to work against it. The problem with CLL is as the B cell matures and reaches that level, the cells, they don't die off. They just keep circulating and circulating and circulating, and they're being nourished by these nurse-like cells. So since they just continue to circulate and don't die off or continue on to that final stage of their life cycle, which is to go into the plasma and become immune globulins, you're going to have a lesser amount of circulating immune globulins. The main one that we monitor is the IgG level. So when you have a lesser amount of those immune globulins, and your immune system then is going to be somewhat suppressed. So these opportunistic viruses like the herpes simplex and zoster and others, Epstein-Barr and several others, then they have the opportunity then to come in and create problems. So yes, there is a correlation between a low immune globulin and those cold sores.
The next question in that same vein is, do you have any recommendations on how to treat cold sores other than using valcyclovir? The questioner says this medication doesn't agree with the questioner, causing nausea and stomach aches, but that's also for shingles, correct?
It is for shingles, but it's used in much, much higher doses for shingles. Valcyclovir or Valtrex, there are others in that class. There's Zovirax and famciclovir, acyclovir, any of them. They're all the same class, just manufactured by different companies. So generally, if they are external cold sores, like on the lips or the crack or just inside the nostril, I generally would give my patients Zovirax ointment, and you can just put just a tiny amount on a Q-tip and just dab that place about 3 or 4 times a day, and it does have a healing effect. In most cases, if the cold sore does not go away, you probably need to see a doctor and make sure that that's all it is.
Okay. Next question. Do you know what causes purple discoloration on the scalp? Questioner is bald, and on the face, on and off, on those with CLL.
Yeah, those purplish discoloration, sometimes it's because you have a lesser amount of functioning platelets, and that's called purpura or large bruises. And it's caused when the blood vessels under the skin rupture or break, and just tiny bits of blood are leaked out into that, just under the skin in that space. So um, particularly, you may see this in patients who are treated with the BTK inhibitors because you have some ineffectiveness of the platelets for patients who are on those drugs. So yes, they may see these large purplish discoloration or bruises on the scalp, on the face, arms, everywhere.
And
But I
those
don't.
are different. Oh,
Go
I'm
ahead.
sorry. Go ahead.
No, I just said I don't want you to be alarmed because it's not uncommon to see those bruises with CLL.
And that's different than petechia, right?
Yeah, petechiae are just tiny, tiny, tiny bruises. Like somebody just took a pen and just did little dots all over the place. It's the same exact thing, except they're smaller It's just little tiny capillaries on the skin that pop and you have little tiny bleeds going on.
Okay. Is postnasal drip a known side effect of ibrutinib, or is it a symptom of CLL?
It
And
can
could having low IgG cause this?
it can be a side effect of ibrutinib. I don't see it as often, but I have had patients who have noticed, and it is in the early clinical trials, it was noted as one of the possible adverse effects of this drug. So yes, that is possible with ibrutinib. Having a low IgG, I don't think it, well, indirectly, because if you can't fight off viruses, then you do know most of the time there are just different viruses that cause the rhinorrhea or runny nose and stuff. So there could be some correlation between the two.
And isn't also well, that we're more prone to allergies? I mean, I feel like I'm more prone to seasonal allergies,
That's
maybe because of my CLL, or maybe just because I'm getting older.
uh, no, it's probably likely associated with the lesser amount of circulating immunoglobulins.
Okay. Um, the questioner has been recommended to take zanubrutinib as a next treatment for returning CLL, but the potential side effects are concerning. What is your opinion of the side effects for this treatment versus other options? The questioner is trisomy 12 and was treated with obinutuzumab in the past.
Um, well, to some degree, all the BTKs, the ibrutinib, which was your first generation BTK, second generation acalabrutinib, and zanubrutinib, and now the pirtobrutinib, which has a little bit different mechanism of action, but all of them has potential to cause hemorrhage, bleeding. The ibrutinib, I think, probably more so than others because we had patients on that drug for years, so we saw it clinically. Um, Increased bruising, you'll see that with all of the BTKs to some degree. Weakness, joint and muscle pain is common for all of them. And the zanubrutinib actually has a little bit better side effect profile than some of the others. There's a lesser likelihood of atrial fibrillation, which was not uncommon with ibrutinib. We've seen it some with the acalabrutinib, but again, it is a BTK inhibitor, so it may be able to cause some cardiac flutter and those type things. I would say of all the BTKs, it probably has a little bit lesser side effect profile.
Okay. How does the prognosis differ for those diagnosed with CLL at a younger age versus those diagnosed after the age of 50?
Well, clearly younger people are in most cases healthier, and so they don't have a lot of the comorbidities that you would have as older patients. You know, when I see patients in clinic, the average age of CLL being around 70 or 72, you generally, they're going to have some other type of health problems like hypertension or hypercholesterolemia, or they may have already been on medication for in some type of heart problems or fluid retention and different things, congestive heart failure. So of course, people who are younger generally don't have a lot of comorbidities. So yes, they are going to have a longer life expectancy. And from the studies we don't see a extreme lot of young people with CLL, but we've seen more over the last several years than previous. So they generally have a better overall survival.
Okay. Do you have any recommendations on how to best manage the risk of secondary malignancies when being on O and V, which is obinutuzumab and venetoclax? And is age a factor in contracting secondary cancers?
Absolutely. So what we recommend, I actually run a survivorship clinic for CLL here at our facility. And my main focus when I see those patients in survivorship clinic is whether they're in survivorship or whether they're in active treatment. We always encourage them to get health screenings. Just because you have CLL and you're getting therapy, you still need to get your mammograms. You still need to get the PSA levels and prostate evaluation according to the American Cancer Society. I know that they are making the guidelines now show the cutoff at younger ages than they have in the past. But get those screenings. An ounce of prevention is better than a pound of cure. So prevent, and what I'm referring to is I can't tell you how many patients I see who come in with skin cancers. It's very prominent in CLL, very high incidence of skin cancers. What you don't want to do is keep exposing yourself to the sun without the proper protection, meaning some very good sunscreen or those long sleeve clothing you can wear that blocks sun rays. Always wear a hat when you're outside, men in particular, because skin cancer is very high. You don't want to end up with the melanoma, which can be metastatic. So wear the proper sunscreen, try to eat appropriately. High-fat diet is known to contribute to breast cancer and other cancers. So I know nobody loves Papados more than me, but there are just some things on the menu at Papados that are healthy. So just try to make healthy choices in food. Make sure you're eating green vegetables and fruit, however many servings that you have available to you during the week. So those are the things that you can actively do to prevent. Now, some things we have no control over, but get those screenings. If you're a smoker or you have a history of lung problems or something, make sure you're getting those serial chest x-rays and just follow up as scheduled with your primary care providers.
I have to admit, I'm a project manager by trade. It's one of my trades, and I keep a little spreadsheet because we're all living so fast. It's like I think I had my mammogram, or I think I did have a skin check, and it's good to keep track of that stuff so you can prompt yourself to make that appointment.
That's absolutely true. And one of the main ones, other than skin cancer, is colon cancer.
Mm.
And I know that is directly linked to high-fat diet. So just think about that, as you're making choices for meals.
For sure. Can younger patients on O and V, again, obinutuzumab and venetoclax, expect a longer remission versus those who are older with this treatment regimen?
I Again, because just the fact that they are younger and healthier, uh, that is theoretically they should have a longer remission. Now, considering the fact that um, we probably don't have the best data in the world on tracking younger people because CLL is not a young person's disease. So the jury may be still out on that a little bit, but the sources I've read, they say yes, because they have better health overall. So they're going to generally have better outcomes. However, patients who are unmutated, that still may enter into the outcome being about on more of an even keel.
Yeah, I was going to ask, would markers play into that and to the length of remission, or do we not really know that yet because these medications are so new?
Yes, that's right. They're new, and we don't have a huge population of younger people. Well, I
Mhm.
guess it depends on how you define younger.
Yeah, 50 is the new 40, right?
Yes.
Um, Are there impacts on CLL, good or bad, if if a menopausal woman uses hormone replacement therapy?
we I have not known that to be the case. We have many of our ladies who are on hormone replacement therapy. Um, that has not been known to be a factor to my knowledge in the past.
Okay. Does taking a high dose iron supplement such as 125 milligrams a day in stage 0 CLL, no other symptoms, would that iron be helpful, or could it cause issues in the production of healthy blood cells on the bone marrow?
Okay, yes, that's a very interesting question. Some people think that taking iron, a little bit of iron, a little bit of B12, and a little more is better. But if you have normal iron stores and your body is making the amount of iron it needs, you don't need to add additional iron. You only need to add iron if you have iron deficiency anemia. And that's easily to find out. You know, the primary care doctor, all they need to do is do an iron panel, and that'll tell you whether your iron stores are adequate. If they are, you don't need to add iron. You can, I'm not sure if people are aware, you can have too much iron build up in the body, and then you'll have to take medications to bind with the iron to try to get rid of. So, no, I wouldn't recommend taking iron supplements unless you need them.
Okay. Will you explain how having CLL or SLL can affect other major organs? If so, are there other tests I should receive to help ensure those organs are functioning well?
Um, CLL, you know, as you know, it's a lymphocytic disease, and so it can be in lymph nodes here, there, and everywhere. Um, CLL doesn't metastasize as people think solid tumor cancers does. It's a bloodborne disease. So it's generally going to be in the spleen or in the lymph nodes or in the bone marrow, of course, in the blood. So generally, the only organs that it's known to affect is the spleen and the liver. And so that's why every time you come in for an exam, I know in my clinic, we always examine the liver and the spleen because it's very important to find out early on what those meant, whether that spleen is getting more enlarged or the liver, and try to do early intervention there. So um, those are the two organs that we know CLL routinely affects.
Okay. Have you seen CLL go into remission after completing R-CHOP treatment for diffuse large B-cell lymphoma? And if so, how long would it last? The questioner is in remission after CLL transformed to DLBCL, and the oncologist is saying CLL will probably return.
Um, well, there's always a chance of CLL returning. Um, we are using R-CHOP now for patients who transform, or what we call a Richter transformation. We're using R-CHOP now, in addition to venetoclax. But yeah, we've seen some good long-term remission with those patients. There's no magic wand that we can wave to tell you exactly how long that patient's going to, but we try to predict that based on all the prognostic factors. You know, whether they had a 17p, most patients who transform do, and most of them are unmutated. So it's so many different factors that you have to look at to determine that. One patient I can think of right now has been in remission over 5 years, who transformed. He had one of the worst Richter transformations I've seen. He was very, very sick. And he has been in remission now for over 5 years. And we see him annually. And he looks wonderful, like he's never even been sick before. Whereas we have other patients who have gone through Richter and have taken the same treatment and maybe wasn't as successful, maybe 2 years remission. So it varies. There's no set number. It's really individualized.
But there's hope there. So
There,
that's good,
yeah.
good to hear those stories. For lactose intolerant CLL patients, what would you recommend best to avoid osteoporosis?
Yeah, I've kind of debated over that question. I reviewed the literature on that. Um, you know, orange juice is a high source of calcium as well. Certain green leafy vegetables are high sources of calcium. Uh, I attended a lecture by a cardiologist regarding calcium intake. And so it seems to be mixed reviews in the literature whether taking calcium tablets are recommended or not. But I guess in the case of someone who's lactose intolerant, there may be an option to take calcium supplements. What you can also do as an alternative is to use lactate and then, drink milk or yogurt or whatever, cheese. Those are all great sources of calcium. But if you use lactate, I know patients who have successfully been able to tolerate milk products with lactate, as it prevents that same type of reaction you would see.
Okay. What are current methods to improve the immune system? The questioner says the immunoglobulin A is 24 and immunoglobulin M is 23.
Yeah, we don't put a whole lot of focus on those um, immune globulins. The main one that's going to boost your immune system is the G, IgM. Um, so I'm not, maybe I didn't fully understand the question. So
Okay.
would you restate that for me?
Sure. What are the current methods to improve the immune system?
Okay. So, um, in patients who, one thing I always try to teach patients is that just because your immune globulin levels are low doesn't mean that that your immune system is not functioning. You still gonna have some function. Uh, and we don't even treat low immune globulin levels necessarily. We don't treat by numbers. Just because your IgG is low, just by everybody with CLL, IgG level is low. So if a person is having recurrent respiratory infections, and especially during the winter months, then we do recommend and prescribe for them the IVIG infusions. Uh, Other than that, there are things, vitamin D. Always make sure you get your vitamin D levels checked. You'd be surprised. So CLL patients, some of them tend to avoid the sun because of the risk of skin cancer. So guess what? When you're not in the sun, you're not getting that vitamin D. And so you may actually that can attribute to a lesser immune system. I sometimes as supplements, and this is strictly a recommendation, I encourage patients to take zinc because that is an immune booster as well. Um, Vitamin C, and try to do it naturally with supplements such as that, and plant-based vitamins if you can. The All the immune globulins are important, and they all have their function in the immune system. But the one that covers the immune system for long-term protection is going to be your IgG. So if we try to replace all of them, that we probably couldn't. The patient probably couldn't afford the cost, because just to get IgG or IVIG is very expensive. And for any patient out there that have gotten that infusion and had problems with your insurance company, you know how expensive it is. So we do know they all play a part in immune health, but the main one being the IgG. And so that's the one we try to focus on.
Okay. This next question, I'm going to try to paraphrase a little bit. The questioner is a caregiver for a CLL patient who's on watch and wait. He was first diagnosed in 2021. His white blood counts have been hovering at relatively low levels for about 2.5 years. He's seeing a well-known CLL specialist and was originally being observed every 3 or 4 months, and then 6 months. And now the doctor says he has no indications of aggressive disease. And the doctor says just once a year. And the caregiver is concerned. Does that seem right? The watch and wait, makes us all crazy. And what are your thoughts?
So what we look at, it is difficult for the patient. And, we try to explain and reassure them as much as possible. If your white count hasn't doubled in 6 months or less, then you're probably okay. By the same token, if you come into the clinic and and you say your white count is maybe 25,000, and we say, oh, everything looks great, you can rest assured that to make that decision, we've looked at that FISH test to see if you have favorable prognostic factors or whether you have a 17p. We do the next generation sequencing where we look at all these different genes, where we look for mutations and try to predict if you have mutations in genes such as Notch1 or TP53 and ATM. All these things tell us you're more likely to progress. So yeah, we may have you come back in 6 months. But if you have good prognostic factors or your FISH test is negative or at worst you have a 13q deletion, we're good with that. And if your counts are not doubling and you come in the clinic and I ask you, are you having dreaded night sweats? How fatigued are you? I don't ask CLL patients, are they having fatigue? I ask them what level of fatigue they're having. And I usually give them a 0 to 10 scale, with 10 being the worst. That helps me to judge there whether this patient is more likely leaning towards needing something or not. So it's not uncommon for us to have a patient come back in 1 year because we've looked at all those different factors and not just the white blood cell count.
And I think especially if you're seeing a CLL specialist, you know, someone who's very familiar with that. It's not,
Right.
you know, and also for us to educate ourselves on those B symptoms. If you're
Yeah.
not having those B symptoms, then you're probably okay.
Yes.
In terms of fatigue, I know I dealt a lot with a very deep fatigue where I would make a salad and then I was too tired to chew it.
Right.
That's a lot of fatigue.
Yeah.
But that's different than just, you know, you raked leaves and then you're tired. There's a
Right.
reason for it. So being
Yeah.
aware and
So
educated.
it is safe to wait a year as long with everything being within the range that we needed to be in.
Okay. Uh, a 78-year-old questioner says, can acalabrutinib create weight gain? I've gained about 20 pounds in 2 years I've been on treatment, and it's located in my abdominal area. I eat well and I exercise.
We did see that more so with the ibrutinib, but again, since it's the same class of medications, it's yes, we have seen some weight gain, and maybe it may be attributed to the fact that you feel better, so you're eating more than what you really realize that you're eating. So again, I would encourage exercise, um, and you know, if you're getting into a remission with acalabrutinib, then work on, the weight. As long as you're not retaining a lot of fluid where you have a significant swelling and edema in your ankles and feet and your hands, then there may be another underlying problem going on. And then we also have to realize as we get older, our metabolism is slowing down. So but yes, I have seen some patients develop weight gain with on the BTK inhibitors, as well as you should also keep close check on your blood pressure. If you're gaining weight, you definitely want to monitor the blood pressure.
Okay. A 65-year-old woman who has been on venetoclax as a second line treatment for about 13 months senses some hair thinning. Is that usual?
If we have seen that occur, it's not as common as you would see with the bruising with the BTKs, but we have had some patients complain about hair thinning with venetoclax. Now, in the research studies that were done on venetoclax, that is not a high percentage of that was shown in the clinical trials, but it's possible. And so again, with venetoclax, you should be hydrating very well. And so that in itself will help keep your body moist and may help with the hair loss. But maybe you can, consult a hairstylist or someone that maybe offers some advice to you.
Okay. Next questioner says, I've just been diagnosed with CLL. At this point, no treatment. I'm concerned about infections and viruses. Several things I've read said live your life as normal, but my normal is often being at church or church activities where there are big crowds. So is it wise to go or should I not?
Okay, number one, you may want to have them check your immune globulin levels and see if the IgG level is, in a reasonable range. Some people with CLL do have really good IgG levels. So that would be one thing I would suggest. Secondly, it's kind of like, all these viruses are out there. So even as a healthy person, myself not having CLL, I'm always conscious of what's going on around me. If I know I'm in a large crowd and there's 10 people around me coughing and sniffing and snorting, I'm going to kind of remove myself from that area or put a mask on if that's what I choose to do. So it's some things that, you just have to figure out what works best. If you are one of those people that gets sick every time somebody sneezes on you, you probably want to avoid being in those kind of situations.
And I also, at that point, I avoid the snacks and all of that. I stay away from that in a room full of people who are coughing because you just, you don't know, you don't want to put that into your system.
Yes, I tell my patients all the time, just, find somewhere else to eat. Stay away from the Golden Corral because you don't know who just coughed, sneezed, or whatever over the food. They picking up the ladles. People don't always wash their hands. So it's not, that was just an example. Buffets in general, you always have to be mindful of that. I know every time I go in Whole Foods, they have this open food bar with salads and hot foods. And I'm thinking, there's no way I'm going to eat anything off that bar because I see people passing by there coughing all the time. So, you know,
Yes. I'm even careful with like shared utensils or the soy sauce container and all of that. So I've always got wipes in my purse. Um,
uh,
Next question. I was diagnosed 2 years ago at 55. My mother was diagnosed last week at 79. What does this mean for my children? The little information I found says it's more likely to be generational in women and that later generations would get it younger. Is that true?
I have seen that bear true in our clinic. I've been in leukemia and CLL for almost 24 years. I have seen multiple families with sets of people in the family. I've seen twin brothers, sister brother, uh, twin sisters. I've seen a grandfather, son, grandson. So yes, it is a familiar. I think the Mayo Clinic did a study on familiar transfer CLL. Um, I don't know that they had any exact conclusions, but I've seen it many times in my practice that we have, even right now, we have siblings that are coming here and that have CLL. So, what it means for your children, we have genetic clinics and stuff now where people are maybe getting tested to see if maybe there's some gene they can predict the likelihood of that they may develop this or not. Now, I'm not a geneticist, but we do have a genetics clinic in our leukemia departments, and I mean you can anywhere. Most places now have geneticists available.
Well, and I think part of that too is once you have CLL and you have other relatives that have CLL, you know what to look for. So,
Exactly.
if with the younger folks, when they're getting their annual physicals for school or whatever, you're watching those things and um, are aware. I know when my SLL was diagnosed, it was just a lump on my neck and I was having cervical problems. So we thought it was a spasm. So I was sent to physical therapy and they were pressing, pressing on it and it wasn't going down. So finally I had some imaging and that's what brought it to light. But it's like, if you're aware that a lump could be that, then you get it checked out instead of going a certain more circuitous route for diagnosis.
Yeah, so because we get many patients who come into the clinic as new patients, and when I look at the labs, and I go back and trend their labs for the last 4 or 5 years, they've had elevated white count all this time. And the primary care, in most cases, I mean, they're primary care providers, so the light bulb doesn't go off if you have a persistent elevated white count. They figure it's a um, infection or something. But with that being said, if your kids are exhibiting any of these symptoms, or they your children maybe early 20s, early 30s, and they start complaining about swollen lymph nodes, you know there's been 2 generations in your family already that had CLL, you know, it would behoove them to go ahead and, you know, maybe get checked and make sure that it isn't. And if
Yeah.
it is, that'll be great. You find out early.
Okay. Next question. Can my CLL diagnosis morph into another type of leukemia or cancer? If so, what are the percentages where this happens?
So again, we have to think about Richter transformation. Generally, Richter transformation, I've seen 2 patients in the last 10 years, I think, uh, that have come in with a Richter transformation from the start. But that's unusual. Generally, when it morphs into that, it's patients who've relapsed refractory. They've already been treated, and now they are coming back with relapse disease, and for whatever reason, it just accelerates. Usually because they have that 17p, or they have a Notch1 mutation, or some mutation that drives this process. And so usually if it's going to morph into another type of bloodborne disease, it'll be the lymphoma, diffuse large B-cell lymphoma, and that is called the Richter transformation. We have had patients who, I don't know that their CLL morphed into this, but we found that they had a concurrent diagnosis of Waldenstrom's macroglobulinemia, where you have too much IgM. And so when patients come in, that's why every aspect of that lab is looked at. When we look at those immune globulins, we don't glaze over them and take anything for granted. And the first indication of that may be elevated protein on your regular chemistry panel. If I see that, I'm going to start ordering, you know, tests to rule out. So those are the things that we do see sometimes that occurs in patients with CLL. And on rare occasions, myeloma, but that is rare.
Okay. Is there an absolute white blood cell count level where treatment is recommended, or is it more dependent on symptoms and other components in the CBC? And they've heard about prognostic doubling time, that's kind of an indicator.
Yeah, so that is an excellent question. I get asked that all the time. No, we don't treat people based on a certain white blood count. We've had patients with as close to 300,000 white counts who still chose not to be treated. But they said they weren't having any fatigue or night sweats, and that's all we can go on if they tell us. So by the same token, you may have somebody with 25,000 white cells, and they having drenching night sweats and have, you know, enlarged lymph nodes to the point of maybe pressing, you know, and it's uncomfortable for them, and they may need to be treated. Um, I don't know how many of you have known Dr. Michael Keating, but that was my first mentor and physician I work with in CLL. And, you know, there are times we treated people, I would say back in the day, with just because they were symptomatic. Not so much now, but yeah, it's many factors. The doubling time, if it's less than 6 months, you know, if you're having these heavy sweats, if you look at that CBC and you notice those platelets and the hemoglobin are trending down, then yes, those are all indications for us to consider treatment for that patient. So it's not based on a specific white blood count. Every patient is individualized. There's no one size fits all.
And I've heard trending too, even one lab that's bad
Yeah.
is not a trigger for treatment, it's a trend, right?
Yeah, because if you just had a cold last week, and it's in your lymphocytes are ramped up because it's trying to fight off that virus, which is most colds are viral, then that's not a time for you to determine whether that's an indication for treatment. It has to be a trend where we see a steady increase in that blood count over time And so when we say a doubling time, we got to start somewhere and figure out where the white blood count has accelerated and doubled.
Okay, I think we have time for one more question here. Is it common for CLL patients to have calcium deficiencies?
That's a question I really don't know the answer to. I don't know what the link is or correlation for calcium deficiency and CLL. That is a question I'm going to have to research that because I just don't know. Most of my patients do not have calcium deficiencies. Matter of fact, they have just the opposite. Many of them have too much calcium because older patients tend to overdo it with calcium supplements. So I've not known that to be the case, but I certainly will research it and find out the answer to that. And I'll be happy to share my email, and you can email me, and I'll be happy to expound on that further for you.
Oh, that's very kind of you, Dr. Jackie. Um, Maybe we can get one more question. Diagnosed in December 2024, lymph nodes are swollen throughout my body. Should I be worried about this without any B symptoms?
Oh, it depends on how enlarged those lymph nodes are and where they are. You know, if you have nodes in your neck and they're so huge you can barely have mobility of your neck and move your neck around, or for instance, I had a patient who came in with loads so large they were size of oranges in his axilla or armpit. So that affects your ability to even do your daily activities and routine. So having the lymph, we all have lymph nodes, and most of us have some swollen lymph nodes, depending on whether we got allergy symptoms or whatever. So just having the nodes is not, it should not be a cause for uh, major concern. But if those nodes keep getting larger and larger and you're seeing more of them, yes, you do need to be evaluated.
Okay, great. Uh, Dr. Jackie, this has been great. I hope that you come back and join us again. Before we close this program, do you have any closing thoughts for our audience? Just some general hopeful?
Yes, I would like to share that I've been working in CLL since before the era of the BTK inhibitors and when they were still using chemotherapy and immunotherapy. And so I've seen it from that point of view. But what I can tell you now, this is the era. If you're going to have CLL, this is the time because they have the best treatments available now. So if you maybe the person who had the obinutuzumab and venetoclax, I believe it was, uh, they have such great treatments, and we still have ongoing research now with even newer formulations of these drugs. So this is the best leukemia to have if you're going to have leukemia right now. I can tell you that the treatments are only getting better. And for those on watch and wait, you just, make sure that you get in a good support group of people, so that not talking to people who has all doom and gloom. You want people that's going to encourage you. And if it's a major concern, talk to your healthcare provider.
Well, thank you so much, Dr. Jackie, for your time and expertise. We're so very grateful for your participation. You really answered so many questions for us. We really appreciate it. And I want to thank everyone who joined us today. And we'd also like to thank our generous donors to CLL Society and grant support from Genentech for making this event possible. A few brief reminders. If you're a Facebook user, please remember to like and subscribe to the CLL Society Facebook page. Please complete the short event survey linked in the comments section on Facebook, and will be shared with everyone who registered through Zoom as well. We really want to hear your feedback, and we appreciate your time in completing the survey. Please join us on March 26th for our next webinar, CLL 101, Biology, Symptoms, and Diagnosis, which will be geared toward beginners and people new to learning about CLL. If your question was not answered today, please send it to our Ask the Expert email service. This is a free service and can be found on the CLL Society website under Programs and Support. Remember to follow the CLL Society on Facebook and other social media platforms. And lastly, CLL Society has invested in your long life. and you can invest in the long life of the CLL Society by supporting our work. Thank you.
Thank you.